kid that comes in with asthma or getting CTs for no good reason, you're not doing that patient any service. So while you will order x-rays frequently, keep that in mind. Also, the second bullet point is you never x-ray a pregnant abdomen. I mentioned that in anatomy, and you can see here, this is the rate of malignancy before 10 years of age. Malignancy, 40% increase. That is horrible. That's why in every radiation department, before the tech shoots an x-ray, they'll ask in 15 different languages, are you pregnant? And if you don't know, or if you could be pregnant, then you need to get a urine pregnancy test, which, by the way, now in grown-up terms, is beta human chorionic gonadotropin, HCG. Okay? Now, if you are pregnant, you can x-ray. If you're pregnant, you fractured your arm, you can x-ray the arm. If you put one of the lead shields, an apron, a lead-lined apron over the uterus. Okay. All right. How you get x-rays. Okay, so there is no bucket of plutonium or uranium in an x-ray machine. There's nothing radioactive about a machine if it's turned off. It becomes radioactive, though, when you apply thousands of volts of electricity, anywhere from 50,000 to 150,000 volts of electricity. That heats up the cathode up here, that because of the heat will expel electrons that slam into the anode, the metal of the anode. Once it interacts with the atoms in the anode, it gives off x-rays. And the x-rays are being given off in all different directions. They're sort of funneled down towards the person who's sitting down here. You can do things that I'll explain a little bit later to focus the x-ray beam, and that's what is done, but that's how you generate x-rays. There's nothing radioactive about an x-ray machine. Now, back in the old days, there was a radioactive source inside the machine that when you wanted to shoot an x-ray like William Rinkin did to his wife, you uncovered the lead shield and the x-rays, put whatever you wanted underneath it, and that's how you got the x-rays. But ever since the 1920s or so, 30s, x-rays are generated now by electricity. I tell a story. Several years ago, there was a medical mission in some place in South America. I don't remember where it was, but they had an x-ray machine there. It was one of the old-timey x-ray machines that actually had a piece of it had a radioactive source in it. So the mission was abandoned, the building, was falling down and everything. The kids in the village discovered this machine, took it apart, and found this beautiful little rock that turned out to be a radioactive source. Not only did it kill all of the children, but everybody in the village was so exposed to the radioactive source that they themselves became radioactive. They all subsequently died. And what they had to do was just bury the village. They had to bury the entire, because it got in the ground, because they would pee, and so they just had to bulldoze the entire village and bury the town because of the radioactive source. But this was a long time ago. Anyway, we don't do that now. All right, so when you take x-rays, you need to appreciate what you're dealing with. X-rays are always in black and white, unless they are color enhanced by some artificial means, but otherwise they're black and white. And there are essentially 4 different densities of gray that you're working on. So when you're talking about black and white, your eyes can distinguish about 20 levels of gray between solid black and solid white. So if you look at an x-ray, this chest x-ray here, there are 4 different densities that you're looking at. And densities are determined by how much of the radiation penetrated you. And remember, this is ionizing radiation. So how much of it penetrated you? If nothing stood in the way of the radiation, and it struck the film back here, and you develop the film, it will be black. If the radiation went through, the X-rays went through and didn't strike anything, and you develop the film, or on a digital X-ray machine, which most of them are these days, if it went through completely unimpeded, you're going to see black. If none of the X-rays were allowed to get through whatsoever, like if you had a titanium rod in here or something, X-rays are not going to get through that, it would be perfectly white. So between perfectly white and perfectly black, you're going to find these 20 shades that are generally lumped into 4. Air is the darkest because that's going to impede the fewest number of X-rays. Most of the X-rays are going to get through air. So your lungs, the bubble on the top of your stomach. There are other places, the colon, your colon, where you're going to have air. That's going to be the darkest. The lightest is going to be the most dense structure that you naturally have, which is going to be bone. That's going to be the whitest. But it's not completely white because some X-rays will get through. So you can see that you can see through the bone a little bit. The more, and this is the thing you need to keep in mind, is that if I'm going to shoot a bone that way, if that's a rib, and I'm going to shoot it that way, the X-rays only have to pass through the bone that thick, right? So if we look at the posterior aspects of the rib, that's what we're dealing with. However, if the bone is turned this way, and the X-rays are coming like that, they would have to pass through the entire length of the bone, right? And it's going to, because it's thicker that way than that way, it's going to appear more white, and that's what you have out here. Keep in mind that what I'm describing is if I have this bottle of water and I shoot through it like that, I'm going to have a different length of going through it than if I shot through it like that. That's all I'm trying to say, okay? So in between those white as it is going to be and black as it's going to be, there are 2 other density levels. One is fat, that is closer to air. And one would be soft tissues like the liver, solid tissues, the pancreas, the liver, things like that, the tongue. They're going to be closer to white. So those are the 4 densities you're looking at. Now the thing about these densities is in X-rays, it's best to tell one structure from another if there is a density, if there is a difference in the densities that are next to each other. That gives you contrast. I know that that's the rib and that's the intercostal space because of the difference between bone and air. If you have 2 densities of the exact same or nearly the same absorption, then the line between the 2 goes away. Contrasting densities is your target here for most of radiology. You can enhance X-rays by doing a bunch of things. One of them is to change the kilovoltage. So if I have poor Kayla here, and she weighs 60 pounds. If I'm going to shoot an X-ray at her, it's going to take much less energy to get through her chest than if I'm trying to get through Brock. In order to do that, in order to get through Brock, to give the same contrast on the film or on the screen that I want with Kayla, I have to change the kilovoltage. And a radiology technician does that all the time. I may shoot yours at 70 kilovolts and yours at 40 kilovolts. They can look at you and tell you how much they need to jack it up or turn it down. I had this guy come into the Kingfisher ER one time. He had abdominal pain. He weighed 700 pounds. He was huge. So, yeah, 700, like 007, just backwards. He weighed, and I know he weighed 700 pounds because the ambulance went through the grain elevator on the way there, and after they dropped him off, they went back through the grain elevator and just subtracted the weight. So I know he weighed 700 pounds. Anyway, his chief complaint was abdominal pain, of course. So I attempted to get an x-ray of his abdomen, concerned about whether or not he was going to collapse the x-ray table, for one. Got him on the x-ray table, and even at the max that machine would go up to, it was not enough to penetrate his abdomen. So in fact, it shut the machine down. So there are limits to a radiography. There are limits. You know, there are also a CAT scan tube. There are limits to your butt being able to get through the tube. So anyway, you need to keep that in mind. All right, so altering the kilovoltage is one. Now the other thing I said a few minutes ago about the, first of all, are there any radiology technicians in here? Anybody with a radiology background? Formal radiology background? No? Okay. The other thing is machines, you used to have to, years ago, put a thing called a Bucky grid in place. And what this does is it filters out all perfectly aligned x-rays. If you get a perfectly aligned x-ray, it's going to give you a more clear picture versus one that's scattered. So fortunately, all x-ray machines now come with Bucky grids, and that's not something you have to physically put into place anymore. But understand it's going on behind the scenes to sharpen the image. The other thing is to use fluorescent screens. Fluoroscopy is a big deal that uses a fluorescent, a cathode ray tube type fluorescent screen or LED or whatever the screens are called now. Like these screens right here. What are these called? This is not an LED. What is that? LCD. An LCD screen. That's how most X-ray machines come now. You don't actually have physical X-rays. They're all electronic now. It's converted to an electronic signal because there's your receiver right there. You don't have old school type X-ray film. This is old school X-ray film. This is probably maybe 10 years old or so. It is, exactly. Well, it's about 10 years old. Anyway, it's of my wife. It's a chest film. Let's see, what was it taken? It was taken in, looks like 2002. This is the way films, X-rays, chest X-rays used to come. You would have to put it up on a light box, which is what this antique thing is right here. This is actually a light box that a person would have in their office, and you put the film on it, and there you go right there. That's what you're looking at right there. That's how you would view an X-ray, right there. Okay? Now, fortunately, they're all electronic. So you can I can pull up X-rays on my laptop and do all sorts of digital manipulations to change the contrast or highlight, magnify, rotate, do anything I want to with images versus the old school way. When I say old school, I'm talking about 10 years. If you want to rotate this image, you have to actually rotate the image. Okay? So, I brought this down here, and I'm going to leave it down here, and you can play with it a little bit because it's really interesting. One of the neurologist who just finished his residency maybe 2 years ago, Anthony. He had never heard of the word Röntgen rays. A neurologist, he just finished his neurology residency, never heard of a Röntgen ray. It's amazing how fast this stuff is moving. So I guarantee you, people your age have never held a film before. And just to let you know, these things were impregnated with silver. It's like a Kodak thing. So you have to develop it. You would run it through a machine, it would develop it. So where the X-rays pass through unimpeded would be black, where they were stopped by the structure would be white. It's a negative. Okay? Okay. What is this? Are we over at 3 or 3:30? 3. Look, I heard. Okay. Points to consider. PA and AP. When you talk about X-rays, understand that this chest X-ray here, I'm taking a 3-dimensional object and squishing it into 2 dimensions, right? So this is my entire wife's chest. The sternum is on here, the vertebrae are on here. They're all on that little piece, that thin piece of film. So, if I look at this, I'm not sure what's going on here. That's a light bulb. So, if I look at this, understand her heart is over here, I think. Okay? If I look at this, there's her heart. So, is this right? Or is that right? Which way do you put it up? So, here's the thing. What I want to do in X-rays, and I'll explain why later, is you want to get the most important things as close to the film as possible. The most important thing in a chest X-ray is the heart and lungs. So you want them as close to the heart, close to the film as possible. So I would put, if this is the film, I would put her like this. So the heart is on this side. Okay? So the X-rays would pass from posterior to anterior. PA versus AP describes the direction of X-rays. Posterior to anterior or anterior to posterior. If I'm interested in a vertebra, I would want her vertebral column as close to the X-ray, so it would pass from A to P. So when you order a chest X-ray, you want to order a PA. Now, most of the time, you're not going to have to tell people that. It's just, you need to understand that the direction of the X-rays is from they first enter the body through the posterior and exit through the anterior. A lateral view would be just as it says. And it doesn't matter unless you're interested in something specific. Like I want the heart as close to the film as possible. So if I'm going to shoot a lateral chest, I'm going to put the film over here because the heart's closest. I don't want to go that way. That's the direction of a lateral. Okay? The whole point is you always shoot an X-ray, almost always, 90 degrees. You get 2 X-rays. All of them are at 90 degrees. And the reason why, can you stand up there? Let's say that S is a bullet. So if I'm shooting a PA, that bullet is going to appear on the X-ray right here. How do I know where in the depth of her that bullet is? You don't with one film, but if I turn her this way, 90 degrees, I can see that the bullet is here. So always shoot X-rays 90 degrees if you're concerned about 3 dimensions. There's always also an oblique view that you're going to see. You'll hear that word described too. Right or left lateral decubitus means you're lying on your side. And I'll show you why in just a minute. Lateral decubitus means you're lying on your side, either the right side or the left side. Now, we were talking earlier about the plain film. This is a plain film. When you say the word plain film, you're talking about just regular x-rays. You always view this, remember if I had it flipped it over, which way is it? You're always viewing plain films as if you are facing the patient. So if the patient is facing me and the heart is on her left side, that's how it would be viewed. So if I'm looking at you, your heart is on my right. That's what happens here. This is incorrect. It's amazing now how many hospital shows you watch, and they always have an x-ray up on a view box. About half of them, 50% of the time, which would be 50% one or the other, they get it wrong, and you'll see that the heart is on the other side. The only time when you're viewing an x-ray, when the heart is on that side, the same side as yours, is if what? And it's put up correctly. What's the name of that? It's what? Situs inversus. You ever heard of situs inversus?
I've seen one.
Situs inversus means the organs are reversed. Instead of rotating to the left when you were a little bitty embryo, you rotated to the right. Situs inversus means your heart is on the right side. Situs inversus totalis means your heart is on the right side and all your abdominal intestines are rotated. So your appendix is on the right, not the left. You never heard of this?
What's dextrocardia?
Dextrocardia is situs inversus
Okay.
of the heart. Okay? I'm surprised you guys have not heard of that. I'm surprised I didn't say it in anatomy. I probably should have said that in anatomy. All right, right and left markers. As this thing right here shows, there's a marker that tells you that this is the left side of the patient. You'll see this here in just a minute. And bubbles with beads. I'll explain that in just a second. I'm going wrong. Oh, yeah, that's good. There's a PA right there that lets you know that this was a PA film. You're rarely, if ever, going to see that on an x-ray because when you order an x-ray, they just automatically shoot a PA. There's the marker to let you know that it's right. If you ever see the heart and it's on this side and there's the right, you need to question the radiology technician. Are you sure you did this correctly? If not, or if they are, I would repeat it to make sure that indeed, or maybe get this thing called a stethoscope and put it on the chest and hear which side the heart is on. You can do that too. Okay? Interfaces. That's what we were talking about earlier about differences between the contrast. Here's the interface. There's the gastric air bubble. You see that little dark area right there? There's a bubble in the top of the stomach. What? You see that line above it right there? Tell me anatomically what forms that line. Diaphragm. And the lungs are above it. So that's what gives you the contrast so you can see the diaphragm. The cardiac sphincter close. The cardiac sphincter is over here, because remember that's where the esophagus is going through the diaphragm. There's another structure that forms that line. The diaphragm and the top of the stomach. We'll find this in the stomach. That's why you got a bubble there. Okay? Did you say top of the stomach?
Yeah.
Then why didn't you speak up?
I'm just kidding, I did.
Oh, you didn't have a freaking clue. The word gastric probably should have given you a little bit of a clue.
You're right.
You're right.
You're
All
right.
right. So here are the things that they'll put on the x-ray table or stick to the screen as they're shooting x-rays to give you some help. This is an arrow meaning up or down, meaning the patient was upright or flat or supine. Here are the bubbles with beads. You see those 3 little beads in there? This is a round ball. It's a plastic ball. And you got 3 little beads in there. 3 little metal beads. If you're standing up, where are the beads going to go? To the bottom. If you're lying down, where would the beads be? They're going to be in the middle. So that will tell you if you're dealing with an upright or a flat x-ray. So if it's flat, you see the 3 beads right there. If you're upright, they'll be down there. Okay? Points to consider, magnification. So here's the reason why you want to put the most important structures next to the film, or next to the screen. Because the further you are away from it, the more artificial magnification comes into play. And that's illustrated here. If we take the sternum, or let's say that's the heart, and you put the heart next to the film, the x-rays are going to come out. What's going to show up on the film or on the screen is going to be almost the size of the organ itself. If you back it up, then it's going to appear abnormally enlarged. That's how magnification works. Some points to consider, follow-up exams. If I shoot an x-ray of this guy's chest tonight, and I mentioned this before when we were talking about pathophysiology, if I admitted Alex for pneumonia and she's satin, her oxygen saturation is 84%, which is really bad. And I started on steroids and antibiotics and breathing treatments and all sorts of stuff. And the next day, on her x-ray, sure enough, she's got a bad pneumonia. On the next day, I reshoot that x-ray because she's getting worse. That's a follow-up exam. Following them, if she's getting better or if she's getting worse, I can document that with an x-ray. So don't be afraid of ordering follow-up exams. Horizontal films for air fluid level. Here's one right here. So this kid had an air fluid level when they were standing up. Was that fluid in the lungs or around the lungs? It was around the lungs, because when you put the kid in the decubitus position, now you see the fluid is down here at the bottom. If the fluid had been in the lungs, it would not have shifted. Upright versus en face. Here's upright. Understand that I can see an air fluid interface in this bottle. I can see that air fluid interface. However, if I'm looking at it from above, this is en face. You do not see an air fluid interface. All I'm seeing is fluid. So you have to keep that in mind when you're, if you're looking at something in particular. You want to make sure you let gravity work for you and help you identify the air fluid interface. You understand why, if this was an interstitial pneumonia and the lung was full of fluid, or they had pulmonary edema from congestive failure, and the lung was full of fluid, you understand that if you put them in a decubitus position, you're not going to see a meniscus, because the lung, the bag, is full of fluid. It's not going to shift like fluid around the lung from this effusion. Okay. Two densities side by side, I said you'll lose the margin. That's called a silhouette sign. When something forms a silhouette sign, that means you no longer can see the margin. Remember that when I told you back in anatomy, the lady that had the renal cell carcinoma? And the only reason we knew that is because she had a pneumonia that was sitting next to her mediastinum. That produced a silhouette sign, so the radiologist couldn't tell where the mediastinum stopped. It was because of that silhouette sign that saved that woman's life. Okay? Now, If you take something of one density and put it into something of another density, you can see it. If you surround it by a different density, that's called a bronchogram. If it's air, it's called an air bronchogram. And here are two examples. Here we see this right middle lobe pneumonia is next to the right coronary border. You can't make out where the heart stops and the lung starts. This is the silhouette sign. You can also see the air-filled bronchus there's the trachea, and there goes the bronchus right there inside that density. That's the air bronchogram. You see that? You can see it on that x-ray over there too. You can see the air-filled structure inside the mediastinum. Okay? You see it right here? There's the trachea right there in the middle of that, the vertebra. There it is right there, big as Dallas. I gotta turn this off because this is an old light bulb and it gets hot. That's how old school that thing is.
What is RML standard there for?
Right middle lobe. How many lobes of the lungs you have? You better freaking answer this correctly. Five. Five, okay, there you go, all right.
We want their lungs to be expanded when we take these x-rays, right?
Yes, what you want the person to do, now you're gonna get into this is just an intro. They'll tell you about chest x-rays later on. But basically what you wanna do is be able to view the 10th posterior rib. So on her, this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? If you don't see 10, then you have a poor quality film, you need to send them back because your license, your liability is what's on that film right there. If it's a poor quality film because they didn't inspire enough, then you're responsible for it. If you miss that liver abscess or something going on because they didn't breathe in as much, it's your butt on the line. So if you don't like the film, make them reshoot it. Okay? Portable films, if they can't go to x-ray department, make the x-ray department come to them. Those things you see them driving down the halls of the hospitals. The problem with portable films, and these are usually reserved for the sickest people or for those that can't transport because they're on a spine board with a C-collar. There are two things that you need to keep in mind with a portable film. One is they don't generate enough electricity. They're limited in the amount of power and penetration they can have. So the films are usually not of the best quality because of that. And the second is the patient is not usually in the most appropriate position. So in this example here, if you're going to shoot a chest x-ray, if you're going to shoot a chest x-ray on me, you're going to stand up next to the screen, you're going to put your arms up to move your scapula out of the way, and they're going to shoot, take a deep breath, and they're going to hold it, hold it, hold it, hold it, so it's going to take several seconds. But if you have this patient right here, well, they're in a bed, you've got them propped up in the bed, you know, got the head of the bed elevated, half of the bed elevated, and you've got the screen behind them, and so she's lying there in a bed, and you've got the thing, you're shooting it like this. So that's why it looks like they're reclined. It's also an AP, not a PA, and also it's at an angle, so her heart's going to look massive, which it does in this film. All of that is artificial. But what it does tell you, though, is she's got a pretty healthy effusion over here. The lungs are gunky, and there was gunky over here too. So this is a pretty sick person. Okay? Any questions? What? What are you grinning about?
I'm just laughing because I worked in the pharmaceutical ICU and this is like story of our life.
Yeah, if you're in the ICU or if you're in the dealing with the ER, a lot of trauma, they actually have the machine down there. They don't even bring it down from upstairs, it's there. And the problem is you're having to make a read off of a technically poor quality film. You would never accept this film if you came into my office and we shot it, okay? Never would you accept it. You also, you can't even count down, you can probably only see about 6 ribs there. So but it does tell you she's got a, that would explain why you've got an oxygen saturation of 80%. Okay. Points to consider. You can highlight things by either injecting in a vein or having them swallow or shooting up their butt metallic containing solutions. Or oh, by the way, 2 terms you need to know. Radiolucent means you can see through it. Radio opaque means you can't. Using contrast material here makes things radio opaque. And there are a whole bunch of examples here. This is a barium swallow. You swallow this barium solution. Barium is a metal, and it's radio opaque. It doesn't give you the outside of the, it doesn't give you the outside of the esophagus. What you're looking at is the lumen of the esophagus. It's the lumen that you're looking at. Of course, this is an angiogram. Over here is a coronary angiogram. This is a barium enema. They used to do these things all the time. They lay down, put a pipe up your butt, and dump a bunch of barium solution up your butt. And what it does, understand, that it outlines the lumen. If you have a cancer, if this is, I knew I was going to do that. If this is the lumen of your gut, here's the wall, you've got a cancer right here, the barium enema is going to appear normal. Because you're only highlighting, the barium is filling up the inside. So it has limitations. The only time where this barium enema becomes important is if there would be a filling defect indicating that there's a mass there preventing the barium from being there. Okay? Look at that plug. I mean, even the plug is old on this thing. This thing is like 10,000 years old. I stole it from, I think it probably says University of Oklahoma Health Sciences Center somewhere on it.
You just borrowed it.
Oh, by the way, before I forget, April 1st, mark your calendars. The PA program is going to provide lunch for you in here. We're going to sit down with you guys, all of the faculty and staff. We're just going to have a chat, informal chat.
April Fool's, don't give them a
It's Friday, April 1st.
Are you being for real or is it April Fool's joke?
No, it's not, no, it's for real. I even made a note to tell you. What does it say? It says lunch, okay? We'll provide lunch for you in here.
Well, thanks.
All right. What are we talking about? Okay. Other things is, another thing to talk about here is calculi, stones. Understand that renal stones, kidney stones, are made primarily of calcium. Calcium is a metal, and if concentrated in a place, it becomes radio opaque. 75% of kidney stones will show up on a plain film. Most gallbladder stones, though, are made of cholesterol. They do not show up. However, about 1/4 of them have enough calcium in them to show up on an X-ray. So if you came in with right upper quadrant pain, and I'm thinking, okay, what is my differential? One of them is kidney stones. One of them is gallstones. If I think it's kidney stones, shooting an X-ray, I got a 3 or 4 chance of seeing it. If I think it's a gallstone, I only have a 1 in 4. What's the point? Get an ultrasound or a CT. By the way, if you don't know what a gallstone looks like, there's one right there. That's a gallstone.
What?
Okay, that's a gallstone. It came out of a cadaver. And so I had that thing for 20 years. I don't know why. But that is the outer surface of it. You see the inside is radiolucent, the outside is radio opaque. And that's why you have these little circles. They look like little circles instead of solid rocks. Okay? Any questions about that? Okay. CTs, CAT scans. The way these things work, now these are ionizing radiation as well. So these are like X-rays. What they do though, is they put you in a tube, and this machine, instead of the X-ray gun being at a single point, it rotates around you. And it takes X-rays of you in a three-dimensional slice. And the penetration through the tissues is summed from all of these different points in the arc. And it shows up on the screen over here as an image. The same things that apply to plain film X-rays apply to CTs in terms of densities. You know, if you take something like the brain, it's going to show the brain in a general form, but you don't have any contrast in the brain itself. So it's just going to be a grayish blob. The thing though about CT is though they, with plain film you can only recognize 20 shades of gray. 20 shades of gray. They're not 50. They're only 20. But in a CT scanner, it can separate thousands, a couple of thousand different shades of gray. But if you looked at all of the different shades of gray, then you did a CT on somebody, it would just appear as a gray mass. You have to interject contrast into the situation. So if you see up there on that, this thing, the shades of gray with a CT, by the way, are called Hounsfield units. 0 is the contrast, is the density of water. And then you go from air, which is all the way black, is a negative 1,000. Metal or pure solid is white plus 1,000. So what we're going to do is we're going to decrease the amount of grayscale that a CT actually will analyze. We want to decrease that grayscale to stay, instead of 2,000, we want to decrease it to minus 100 to plus 100. So that everything less than minus 100 will appear black, everything more than 100 will appear white. That's how you introduce contrast into a CT. You can sit there and dial in and out the windows of the Hounsfield units. That's how that works. Okay? This is a CT here, or a series of CTs. By playing with the machine, you can do all sorts of manipulations on this cross-section of a chest. Now understand that CTs are slices. So if I'm going to get a CT of your chest, I may get 50 slices through your chest as you go through this tube. But each slice is going to be separated by 3-4 millimeters, something like that, or maybe even more. If I'm interested in your pituitary gland, though, I want the slices to only be like a 0.5 millimeter apart. So you can actually, you don't have to physically do this because a radiology technician automatically does it. If you order a CT, you'll get a set number of slices. If you order a CT of the pituitary gland, you'll get a set number of slices. They adjust the slice thickness based on their education. You don't have to worry about it, okay? But you follow me, okay? In these images up here, you don't see much detail in the way of the central nervous system here, but you can see that there's a density difference between that thing and the other side. Similar over here in the posterior cranial fossa, there's something big going on that's different than the rest of it. And over here, because it's a computer, you're taking slices You can sit there and say, okay, I want to see Alex not in a transverse plane, I want to see her in a coronal plane. The machine will easily change the structure of the plane, the orientation of the plane, based on whatever you tell it to. Very handy. Now, understand that if we look at this CAT scan here, there's the heart. Am I looking at the slice? If I have a slice, am I looking at the sliced person from the feet or from the head? Well, yeah, it's from the feet, because that's what the next thing says. CTs are viewed as if you're standing at the patient's feet, looking up towards their head. And the reason this became the convention is because in neurosurgery, when CTs first came out, people would, one neurosurgeon would always view it from the bottom up, so the patient's left was your right, and another neurosurgeon would always view it the other way, and they'd wind up going in there and realize they were on the wrong side of the brain. So by convention, it was established that CTs are always viewed, and MRIs are always viewed as if you're standing at the patient's feet looking up at their head. So in this one right here, if I'm at your feet, the heart is going to be on their left side, because they're like this, right? Heart's on the left side. A CT, just like a plain film, is good for bones, head, neck, chest, abdomen, pelvis. Where you've got bones, you've got contrast. It's not good enough for soft tissue injuries or soft tissues overall, because there's not enough contrast in soft tissues. Of course, you can enhance it with IVs just like you can plain films. MRIs came out or were introduced into healthcare much later than CTs. But the MRI machine was actually invented before the CAT scan, which is interesting. MRIs are interesting in that they do not use ionizing radiation. So while you want to limit CAT scans, you don't have to limit MRIs. They don't produce any ionizing radiation that's bad for you. What it does is it exploits the magnetic properties of water. If, for those of you in the know, water has a couple of hydrogens and an oxygen. So what you want to do is you want to stick this person into a magnetic field. So if we've got a negative pole here, if we turn the magnet on, you know how magnets, they oppose each other sort of thing? There was a thing where a guy was circulating a petition to ban the use of dihydrogen oxide. And he got all these signatures, and after people would sign it, they said, "You do understand that I'm trying to ban water."
Yeah.
And did you see that? It was stupid. It was just amazing. Well, anyway, if you turn the magnet on, all the positive charges will tend towards this side. You turn it off, and then they go back to their native state, random. But when they go back to their native state, they send off radio waves that you pick up. That's what you're looking for in an MRI. You're looking for the generation of radio waves. So therefore, the quality of what you're trying to image depends on how much water you have. The brain has a lot of water, so it's very good for the brain. The bones do not have much water at all. It's not good for bones in themselves. You would never do an MRI of just a bone. You could do an MRI of a joint because of the soft tissues around the joint, but not of the bone itself. If you're interested in the bone, get a CT or a plain film. Contraindicated in people with aneurysm clips, pacemakers. Well, because it's a magnet, you don't want to wind up having, their pacemaker doing like this as you're trying to Actually, surgical stainless steel is not magnetic. But as a precaution, they don't want you in an MRI tube. They say that when you go get an MRI, you have to leave, and I had to do this, I had to leave my wallet outside the MRI room because the magnetic field that the thing generates is so massive, it wipes out all of the little strips on your card. So you have to leave the stuff outside. It's not painful. You don't feel anything other than being in a very tight confined tube for seemingly forever. Any questions about any of this? So here we go. We take our random head. We get our random molecules, and you turn the machine on. They polarize. You turn the machine off. You generate waves, and this is what you see. You see it's very fine detail, amazing what you can see with an MRI. The thing, though, is you'll hear when you get MRI reports, the radiologist will say in a T1 weighted series, blah 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 blah. T2 series, blah 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 blah. T1 and T2 is just a switch on the MRI, on the computer, that makes water or liquid, like cerebrospinal fluid, either black or white. So in this image up here, the CSF is black. In this image over here, the CSF is white. So it gives them an ability, it's an artificial, just a button they push on the computer that they can switch. But you will get MRI reports back and say, in a T1 weighted image, this is what I saw. You can see in this ankle here, the ligament, the plantar ligaments here, the tendons, it's just truly impressive how much detail. Of course, the bone itself just appears washed out. Okay? Any questions?
So T1 always correlates to the pure fluid being black?
I don't even care that you know which one's which. All I want you to know is that when you see T1 versus T2, it's just the radiologist saying, in that enhancement, this is what I see. You don't care that it's which enhancement. Just don't get like, oh my God, what does T1 weighted mean? You know, does that mean that the patient was standing like this versus like that? No, it's just a button on the machine. Ultrasounds. You need to take a break? Can we go on? Ultrasounds. Is this the last lecture of the day?
No.
Oh, God. Ultrasounds.
Tell me about
You
it.
don't even have to
Yeah,
go
I know.
tonight.
You don't have to be there.
Sucks to be, well, yeah, wait a minute. I was there before you were born.
You're right.
Röntgen was the guy that. So ultrasounds, just a very high frequency, because it's not ionizing, and it's not like microwaves that generate heat. It's very useful. It's bedside. These things have become so portable. They're about the size of a banana. I mean, you can do. I was going to say something else. I couldn't think of it. Anyway, oh, I see who lit up with that reference.
Quit.
You too. You too. Y'all explain it to the others. Okay?
I see.
All right. Anyway, bedside ultrasound has become the norm now. It's best on watery substances. It's bad. It's not good on substances that don't allow transmission of the ultrasound waves, and that would be air and bone. It won't travel. They travel poorly through air, and they will bounce back on bone. So that's why you don't ultrasound the chest. There's too much bone and air to get through. I don't know anybody's ever ultrasounded the chest, other than looking at the pericardial sac for the presence of fluid. Okay. There are no fixed projections like in radiology. There's up, PA, lateral, there are always fixed projections. But in ultrasound, you just take it and put it on the skin and rotate it whichever way you want to. Now, there are some things that are standard, like in obstetrics, they will measure the length of the femur to determine the child's age. But, generally, there are no fixed positions. I have the hardest time making heads or tails out of ultrasounds. Because unless I'm holding the transducer, I can't get oriented like what's up and down. So, anyway. Because the energy levels are so low, you can use them in OBGYN to do all sorts of stuff, imaging the fetus, and you can do it multiple times. Now, just to be on the safe side, they say that you shouldn't do more than 2 or 3 ultrasounds during the pregnancy. But there's no study that shows that, if you did one every week, there was no harm to the fetus. My wife, when she worked in the clinic, our friend was pregnant, and like every 2 days, they were down there ultrasounding the fetus, and they were so happy that they discovered that it was a female. And when they asked me to come down to confirm, and I looked, and she was showing me what she thought was she thought the kid was a male, and so thought that here are the testicles. Well, she actually was looking at the head. And when you're looking for male and female, you're not looking for testicles. What you're looking for is 3 little lines in the perineum, the 2 labia. That's what you're looking for. You're not looking for testicles. If you don't see the 3 lines, you're a male. If you see the 3 lines, you're a female. In Larry's case, they were both there.
Happens.
Sometimes you just get what you get. Now, a Doppler ultrasound, so an ultrasound is a transducer. It's generating the ultrasound waves that are striking something and bouncing back. So you're transmitting and picking back up. So what a Doppler does is that so if this is the transducer, and I put it, and this is an artery right here, and I put it on the artery, when the ultrasound goes down, it strikes this piece of blood. Well, this blood is traveling, so it absorbs the ultrasound waves, and now it has moved over here, and it reflects them, but it's now not in the same position where it absorbed them. So there's a distance there. Doppler takes advantage of that travel time and lets you detect things that are flowing. It's like if you're standing by the train track and the train comes, that's the Doppler effect. The sound waves are compressing, or you get what I'm saying, right? You don't get what I'm saying. Does anybody not know what I'm saying?
It just lets you detect movement.
It detects movement. It's an ultrasound, but because it's absorbed and now it's reflected them in a different place, you pick up on that movement. So if I'm looking for a DVT, I want to make sure that your veins are open. So I put my transducer on your vein here, your popliteal vein, and as the flow of blood goes underneath it, what I hear is a swishing sound. That's how I know that blood is going through there. If I am out playing basketball and all of a sudden I get an excruciating pain in my scrotum and I present to the ER and they're concerned about testicular torsion with a decreased blood flow to my testicle, they're going to do a Doppler ultrasound of my testicular artery to make sure that there's flow there. You can actually color enhance